I'm Jackie Brady, and along with Dr. Strickland, we're the co-PIs for the Bridge Registry, and Dr. Wittstein is our lead writer and the true scientist among us. So she'll get into the weeds a little bit on the data, but I'll give you a little bit of an intro. So let's talk about the Bridge Registry. Like we said, this is the multi-center study that's allowing surgeons to be unencumbered by the original technique. And also not necessarily directed in terms of timing. And so we get a little more variety here. So the projected end date is 2027 to get our 750 patients enrolled. So far, we have 224. You can see the sites listed here. We completed our 1-year analysis in September, and so that's what we're going to focus on here. The goal here is a post-market clinical study that will be continuing to collect data on patients treated with the Bear implant in a commercial setting. So unrestricted inclusion, exclusion criteria. You saw the age range of 7 to 70, I believe, before. So very wide range that we can include here. So current enrollment 224. We have 9 sites. We have 152 patients that have reached 1 year at this point. We have 76 that have reached 2 years. And then we'll see the interim analysis here with this first 100. So this is the first 100 subjects at 1 year. Of those, 29 are at 2 years. So a little bit of a range. 4 of the subjects exited early, 1 at 3 months, 2 at 6 months, and 1 at 9 months. Of the 100 subjects, 94 of them were retrospective. And so we caught them at their first post-op visit after the study was begun. And then 6 are prospective. And you can see the enrollment distribution here for those first 100. And then here are the demographics. So the age is pretty well distributed, more female than male, and mostly proximal tears, but a good number of mid-substance and 1% distal. And then I'll turn it over to Dr. Wittstein here.
Thanks. And then Jackie, can you go back to that last slide just for one moment?
Yeah.
The other kind of aspect to zone in on there is that the mean time from injury to surgery is also, like the age, much broader. So, we've got a minimum of 8 days, but a top number of 154. So, with surgeons judging intraoperatively, looking at the ACL stump at the time of repair, kind of determining that this is still appropriate based on the quality of the tissue, but still a much broader range. So, okay, next slide. All right, so we mentioned the tear types, similar to other studies, these tend to be utilized on more proximal mid-substance injuries. Looking at our surgical techniques, we had one associated with an LET. And one of the things that really sets this study group apart is that there are a lot of modifications in the technique used. So 50 of these subjects in this group of the first 100 had the classic, Martha Murray technique that Keith so nicely described. But 50 had modifications. And when we say modifications, what we're talking about is any modification from that standard technique. So it could be luggage tag sutures were used instead of Bonnell's. The ACL suture instead of Vicryl might have been a suture tape or some other, higher strength suture. An anchor could have been used on the lateral wall of the notch versus a button, or a tibial anchor instead of a button for the fixation on the proximal tibia. And then alternate bracing sutures, so that suture that you pass through the Bear implant using tape or something other than Ethibond. Next slide. Our overall reoperation rate at 1 year was 8.4%. When we look at this whole cohort, including, in this first 100, including those that were at 2 years, there's a 2% re-tear rate. Both of those re-tears occurred between 1 and 2 years, one in a 17-year-old with a non-contact pivot injury while playing basketball at about 14 months, and then another in a 15-year-old while playing hockey at 23 months. So right near the end of that range that we were catching data out to 2 years. There was a single contralateral injury that occurred, and then 4% of this group sustained meniscus injuries. Other surgeries that were performed were manipulations under anesthesia, and then removal of the Ethibond suture from the notch in 4 of these cases. Next slide. Our PROs are a little different than those that Keith so nicely presented in the Bear 3 series, partly because in this first 100, so many of them were enrolled after the initial surgery, so kind of catching them at that first post-operative visit. So we don't have that great preoperative data in some of this group, but looking at our PROs at 1 year reported in 79 of this 100, you can see these patients have high IKD scores. The MARC scores with an average of 7.5 are certainly a lower activity level than they were at 1 year in the BEAR-3 group. RSI is about 67. The Q scores were all quite high, as you can see there. Looking at the physical examination, this is available in 75 of these 100 patients. The overwhelming majority of them had very little translation on Lachman, 0 to 2 millimeters and 80%, and then 3 to 5 millimeters of translation and 20%, with a firm endpoint noted on most of these patients. The pivot shift was performed in 73 of the 100 at 1 year. A lot of these patients are missing some of that physical exam data due to virtual visits at 1 year to confirm that they hadn't had any re-injuries. We'll see larger numbers of physical examination going forward with the registry with all in-person follow-ups, but in the pivot shift for this group, 90% of them were negative, 8.2% were grade 1, and a very small fraction, 1.4%, were grade 2. So looking at the technique modifications, the registry was not designed to compare modifications versus traditional techniques, but we are seeing in the course of the registry over time, increased utilization of technique modifications, especially with increasing use of the button on the femur, the anchor on the femur rather than the button. We didn't see any difference in safety outcomes when comparing the 50 that had the procedure by the classic technique and those that had a modification of some sort. The most common modifications we're seeing again, or use, at least in this first 100, then also going forward, is use of the anchor on the lateral wall. In this first 100, only 17 had the anchor rather than the button, but you'll see going forward there are more people doing that. Using a tibial button versus anchor was another common variation. In this group, the anchor was used in 43 out of 100. And then again, using alternative ACL stump suture, you can see here what the distribution there was. So in this group, 84 had the vicryl on the ACL stump, but other sutures were used in 16 of these cases. Luggage tags were used in 13 of the cases as opposed to Bunnell. And then using an alternative suture to go through the bare implant, we see that 39 out of the 100 used an alternative suture other than Ethibond. A lot of these were suture tape. Next slide. Looking, when we say inclusive of all subjects, we mean the whole group that's been enrolled in this registry, not including, beyond the first 100. So now you can see there's an even greater shift towards use of modifications. If you look at femoral fixation, looking at these 224 patients, there's a little bit higher use of the anchor. Now we see 30% with the anchor. The tibial fixation, I would say, is pretty similar. We're seeing 55% use of the anchor. Alternate stump suture, still seeing majority being done with vicryl, but you can see like some gradual increased utilization of other types of suture. And then the suture that's passed through the bare implant, definitely seeing a greater shift towards suture tape and things other than Ethibond. Next slide. So just so people have an image, we wanted to show you a couple of examples. So this would be an example of using the bare implant with luggage tags and a femoral anchor. Just a little notchplasty there. And then these are luggage tags instead of the Bunnell suturing, and then those are taken to an anchor on the lateral wall. Next slide. And then here's the passage through the tibial footprint and then placement of the dunking suture. And then you can see that there are those sutures that are exiting from the anchor on the femoral wall, which will be used to pass through the bare implant. Next slide. Another technique is the bare implant with Bunnell stitch and a femoral anchor. So the Bunnell stitch is, of course, the classic technique, but the anchor is the variation. So here's Bunnell suturing, and then this is placement of an interference type anchor on the femoral wall to secure it. So that's different than attaching it to a button, clearly. Next slide. And then the third variation we just wanted to highlight is use of the bare implant with a ring type suspensory device. So this would be passing. Here we're just showing the prep here. Next slide. This is kind of drilling, from the outside in. And then these are rings that you can pass a tensionable suture loop through. Next slide. And then the tensionable suture loop is pulled in just like you would pull in the button on a traditional technique. Next slide. And at this point, you can partially tension the tensionable suture loop. And you have 4 tails of suture that were also passed through that button that can be used to go into the bare implant and then completed, and you can subsequently tension the implant, the tensionable suture loop more if you want after you've inserted the bare implant. So, next slide. In rare cases where second look arthroscopies have been done, this was a case or two, I think, with arthrofibrosis. There was a limited number of those, but you can see here there is quite a lot of collagen here, and that looks like an ACL that you might see in the setting of a little arthrofibrosis that we don't want to get too close to, but there's definitely a very recognizable structure within the notch there. So next slide. I'm gonna let Jackie wrap up with the last slide here.
Right. So yeah, we're hoping to continue our projects here. We've got abstracts submitted to ANA and AOSSM for the safety data and the physical exam and outcomes of these first 100 patients. We're hoping to create a publication of all the various technique modifications that have been used for the public to be able to reference as they take on the bare procedure. And then because some of these outcomes seem to differ, we're hoping to compare our cohort to the bare 3 group. And we're working out how to do that in the most valid way, because we can talk about modified technique, but that really includes a lot of variations. And so we want to make sure that we're pure with our data there.